Hey, my name is Adam Kittai. I am an assistant professor at The Ohio State University, and I specialize in the treatment of chronic lymphocytic leukemia and Richter's transformation. On Monday at ASCO, I'll be presenting a poster that compares acalabrutinib and zanubrutinib in a MAKE analysis. So in this particular study, we looked to compare statistically acalabrutinib versus zanubrutinib. The importance of this is that these are both second-generation BTK inhibitors that have not been compared head-to-head and most likely will not be compared head-to-head in a phase 3 randomized control trial. There were two trials that were recently published in Relapsed Refractory CLL, Elevate-RR and Alpine. Elevate-RR compared acalabrutinib to ibrutinib, and Alpine compared zanubrutinib to ibrutinib. Both of these trials occurred in the relapsed refractory setting, and both showed a significant side effect benefit of the second-generation BTK inhibitors acalabrutinib and zanubrutinib versus ibrutinib. What was interesting was the zanubrutinib versus ibrutinib study, Alpine, also showed an efficacy benefit of zanubrutinib. And so there was a lot of talk about comparing these two specific trials, Elevate-RR versus Alpine, and assuming that zanubrutinib might be the superior BTK inhibitor to use in the relapsed refractory setting, even though it's never been compared to acalabrutinib. The problem with comparing these two specific trials is that Elevate-RR only included patients with deletion 11q and deletion 17p disease, making a cross-trial comparison for these two studies not a great idea, as there is two different patient populations. So what we did was we compared the ASCEND study, which was acalabrutinib versus physician's choice, bendamustine plus rituximab or idelalisib plus rituximab, to the Alpine study, which I just stated was zanubrutinib versus ibrutinib using a MAKE analysis. So a MAKE analysis is a statistically validated way of comparing two trials without doing a phase 3 randomized controlled trial, where it doesn't matter whether or not the drugs were compared to the same competitor. So this is called an unanchored MAKE, when the comparator arm is not the same. Whereas an anchored MAKE would be comparing two trials that had the same comparator arm. So this is an unanchored MAKE that compared the patients who were on the ASCEND trial versus those patients who were on the Alpine trial. So how do you do an analysis like this? So we have individual patient data for those patients on the ASCEND study, and we look to see which characteristics were prognostic of survival, and then we take those prognostic characteristics and we weight each patient on the ASCEND study to match those patients on the Alpine study. That way, we are making sure that the patient populations that are contributing to the survival analysis are similar. That's how you make sure that each of the arms are matched. That's why it's called a MAKE, a match adjusted indirect comparison. So when we did this, we found that the progression-free survival for patients treated with acalabrutinib was the same as those that were treated with zanubrutinib. They had equal efficacy in the ASCEND arm as they did to the Alpine arm. This wasn't too surprising, because when you look at the median progression-free survival for patients treated on ASCEND for acalabrutinib, it was very similar to what was seen on Alpine. And actually, when we looked at the Kaplan-Meier curve for patients treated with acalabrutinib on the ASCEND study, it was overlapping once we did the MAKE adjustments. So there really wasn't a change in the efficacy of acalabrutinib. Next, we looked to see at the side effect profiles of acalabrutinib and zanubrutinib and saw if there is any difference once we made this adjustment. And what we found was that patients treated with acalabrutinib had a slightly better side effect profile than those treated with zanubrutinib for hypertension, hemorrhage, and any grade 3 adverse event. So this is also not surprising, because when you look at the tables of side effects for patients treated with acalabrutinib and zanubrutinib, hypertension was pretty significant in the Alpine study. And so it was not surprising to find this difference in side effects for patients treated with acalabrutinib, even when we did the MAKE analysis. So overall, the take-home points here is using the MAKE analysis, the efficacy of acalabrutinib in the relapsed refractory setting was similar to the efficacy of zanubrutinib when we compared the ASCEND trial versus the Alpine trial, which we think is the more appropriate study to compare in the relapsed refractory setting of acalabrutinib as opposed to the Elevate-RR study. We also found some improved safety signals for patients with acalabrutinib versus zanubrutinib, specifically for hypertension. So overall, I think that this is just good data that just shows us that the second generation BTK inhibitors appear to have equal efficacy and that they are likely to be interchangeable. But this is all hypothesis generating because this is only a statistical adjustment, and what is really needed is a phase 3 randomized control trial, which I'm not sure will happen.